All right, thank you everyone. Dr. Bryan, if you want to go ahead and introduce yourself and then we can get started.
Sure. My name is Nicole Bryan. I'm one of the infectious disease doctors here at WVU in Morgantown, and also one of the providers in our positive health clinic where we care for our HIV patients. And so I think to start off with today, Kaylee, do we have a couple of cases to share? And then we'll get into the didactic portion later on.
So I think what would be easier, since it's the first session, I think we'll go through the case form. And then I can present a case or two, but I was going to relay it back to your didactic. So if you want to go through your didactic first, and then that way we can like apply what you talked about.
Okay, you want me to go first?
Yeah.
Okay, yeah, I'll go first. Oh, all right. Yep, we will do it that way. Give me a hot second here. Let me share my screen. Am I allowed to share my screen, Kelly?
Absolutely.
All right. So I want one second here. All right, I want to share. Sorry, I have two monitors, always confuses me. So I want to share this one and then do this. And then, all right, is that looking good?
Fabulous.
All right, perfect. Okay, so yeah, as I mentioned before, my name is Nicole Bryan. I'm an associate professor here at WVU, and I work in our positive health clinic. And so really what I wanted to do for this session is to really kind of just give an overview of all the different strategies that we now have, all the different tools that we have now to help us with HIV prevention and also our epidemiology, okay? And then as we go forward, we'll have each sessions kind of doing a little bit of deeper dive into each of these topics. So just a couple of housekeeping slides. We are this Project ECHO is done in collaboration with the Mid-Atlantic AIDS Education Training Center. And so we do have funding from the Department of Health and Human Resources, specifically targeting HIV training and education for healthcare providers. And so the views expressed here aren't necessarily official policies of the Department of Health and Human Resources aren't necessarily endorsed. The staff and faculty involved don't have any conflicts of interest to disclose. And I personally don't have any conflicts of interest to disclose. And we do try to make our presentations compliant where possible with the American with Disabilities Act and Rehabilitation Act. If there are any additional accommodations that you need, please contact us and we will try to make sure that we're accommodating you. Okay. So objectives. So I want to spend a little bit of time talking about the epidemiology of HIV infection in the United States and focusing here in our area in West Virginia. And then kind of go through those strategies and interventions that we actually have now preventing the spread of HIV. I'm going to focus a little bit of time on PrEP or pre-exposure prophylaxis, treatment as prevention, and post-exposure prophylaxis. And then also focus on some of the challenges and opportunities for improving access to HIV care in our state here in West Virginia. A little bit of an introduction to us at the Mid-Atlantic AIDS Education Training Center. So as I mentioned, we are funded by HRSA, and it's part of the broader funding for the Bryan HIV/AIDS program. And so this program does provide comprehensive care for people with HIV, and it's broken up into different parts. And so our part here for the AIDS Education Training Center is under Part F. And again, with that focus on providing education to healthcare providers to make sure that they're up to date for the best care for HIV, people with HIV, but also with prevention. And so it's actually a national network. We are a partner under the Mid-Atlantic program. And again, here's are some of our goals and objectives. I'm not going to go through all of them, but you'll have access to these slides in the future. And if there's any other future training that you would like for your area, just reach out and let us know. So starting first, so in 2019, you may be aware the US government actually announced a national commitment to ending the spread of HIV in the country by 2030. And it was actually a cross-agency initiative across multiple federal programs, including the CDC, NIH, HIV.gov, HRSA. All of these federal programs really got together and said, you know, we really truly have the tools to actually end the HIV epidemic. It's really implementing them and getting them into the hands of people who need them, and also getting access to patients and individuals who are at risk. So we really have the science in place, as I'll show you. And so now we really need to implement that and get that in the field. So the CDC sort of divides this up to geographic distributions. So we in West Virginia are in this purple area. We're at the very tip there. That's our northern panhandle sticking out there of the southern region. And actually, HIV in the United States is not uniformly distributed, and new infections in the United States aren't uniformly distributed. And you can see there's actually a focus in the southeastern region of which we're a part. So a lot of interventions have been focused on these key states. So what about in West Virginia? So West Virginia classically has been a very low incidence state. Most counties had 0 new cases of infection per year, or they were in the single digits. That has changed for us. We have had several new outbreaks dating back to 2017, predominantly in our southern counties. And this does really track along with the opioid epidemic and increased use of injection drugs in our state. And since we've had that larger outbreak in the southern part of the state in 2017, there's also been other sort of focal areas and clustered outbreaks in other counties, which are shown here. And that includes our county here in Morgantown for Monongalia County. Many of these are related to injection drug use, though not all of them. If you'd like up-to-date information on what's going on in our state, the State Health Department has fairly recently created this HIVaware.westvirginia.org site. So I encourage you to go check it out. They update this about every 2 weeks or so, and you can actually look and see what are the county numbers throughout the state for areas where we're starting to see an increased number of HIV cases. So I just highlighted some of the counties where we have some higher numbers. You can look at it this way on the map, but you can also look at a table. This is just a few sampling of counties that I showed you on the map, but you can also do table form, and it goes all the way back to 2015. And then it gives the totals for every county in West Virginia. Those that just have an asterisk are basically those that have 4 or less cases, and in which case to kind of help maintain anonymity, they don't report out the actual number yet. And so this is updated every couple of weeks, so you can get a sense of what's happening in your area. Okay. So now going on into different strategies for controlling HIV infection. So we actually have a lot of tools at our disposal here. That we've had since HIV was first discovered in the 1980s, but we really, if we can focus on these 3 areas that I have in red, we can actually anticipate a 70% reduction in infections as it's been done in mathematical modeling. So that's why we spend a decent amount of time focusing on these 3 areas. But there are a lot of different ways that we can tackle preventing the spread of HIV. So behavior modification, so these can include safer sex campaigns, condoms, both male and female condoms, and education. Case finding and HIV testing, which we'll spend a little bit of time talking about today. Blood supply testing. So in the United States, every blood donation is tested for HIV, and the odds of acquiring HIV through a blood transfusion are very, very low, fortunately. Harm reduction plans for injection drug use. Actually, circumcision can also help prevent the spread of HIV. And then now we have medical therapies at our disposal as well. So we have the concept of treatment as prevention, as I'll talk to you about today, where we have treating individuals who have HIV can actually decrease their risk of spreading it to someone else. Pre-exposure prophylaxis and post-exposure prophylaxis, and then measures that we use to prevent mother-to-child transmission. Also treatment of co-infections and other sexually transmitted infections. That's a big one because all sexually transmitted infections, but particularly ones that cause ulcerative lesions, can facilitate HIV transmission. And of course, our long-awaited hope of HIV vaccines, still an active area of research, though we don't yet have one to date. So spending a little bit on HIV testing. So we actually have made a lot of advances in HIV testing since we first discovered the virus. So it used to be, and I can remember when you had to, an individual had to come to have HIV testing and then subsequently have to follow up in 6 weeks because maybe the results weren't accurate for the earlier infections. So now we can have reliable results much sooner. With the 4th generation tests, which look for both an antibody response to the virus and an antigen or a protein that's on the virus itself. And so we have a much smaller window of roughly 2 weeks where you may have a false negative test. There's also home testing kits available just in local pharmacies. And so patients may come to you and have done their own testing at home. And they're actually pretty good as well. Most of them are going to be a 4th generation antigen antibody test. So I always tell our residents and students, if somebody comes to you and says they took a home test and it was positive, I would treat that just as if they told me they took a home pregnancy test and it turned positive. So they are pretty reliable. And a lot of individuals are liking that just because of the anonymity for it and not having to go see a healthcare provider in order to get that test. Current CDC recommendations are that everyone ages 13 to 64 should be getting tested for HIV at least once in their lifetime. So that's across the board, regardless of any reported risk factors. If they do have risk factors, either through sexual exposures or injection drug use, then they should be tested more often. So how are we doing with that? So this was from the MMWR in 2019. And actually, nationwide, it's roughly around about a third of adults will report that they've been tested, but we're not doing quite as well in rural counties compared to urban counterparts. So rural areas of the US are much less likely to receive HIV testing and are oftentimes diagnosed later in the disease process. And this is true for people who are ever tested for HIV, for those who are tested HIV within the previous 12 months at this time, and then those who had reported risk factors. So our patients in our rural areas aren't getting tested as often. So what are some reasons for this? These are just a few. So some individuals may not appreciate that they're at risk, and this might be true for our patients who are at risk, but also for us as healthcare providers that may not be recognizing that the patient in front of us could be engaging in high-risk behavior. Stigma. And the stigma is multi-layered in this sense. HIV, unfortunately, the disease itself still carries a lot of stigma. So sometimes people don't necessarily want to find out their results. Or they may have stigma and not want to disclose to their healthcare provider what types of behaviors they're engaging in that may put them at risk, whether it's substance use or sexual behavior. Also, in our smaller communities, there may be concern for lack of confidentiality, where if everybody in your town knows each other, you might not want to reach out to somebody in your local health department or a care provider to have testing because you might be worried that test result would become widely known. So what are some strategies that we can do to increase our testing rates? So really looking at more universal opt-out screening programs, particularly in emergency rooms and primary care settings, and testing in community-based sites such as health fairs or college campuses, places where other health programs or screening programs or initiatives are in place, so they don't necessarily have to aren't just associated with HIV screening. Maybe more comforting for people to go and have testing done there. Testing at local pharmacies. This is a picture of the mobile testing unit that was developed in the southern part of our state through Charleston Area Medical Center, which is another Ryan White clinic, where they go out into the community, particularly like areas where maybe homeless people might be residing, and just really trying to reach the population that might be at risk. And then also performing them in combination with other key services for at-risk individuals, such as syringe exchange programs, medication-assisted treatment for opioid use disorder, or STI clinics. So really trying to broaden our concept of where and when HIV testing would be appropriate. Treatment is prevention. So once somebody is identified as having infection with HIV, getting them on treatment as soon as possible really actually can help slow the spread of disease and make them less likely to transmit that to anyone else. So what's the rationale here? So the major risk for HIV transmission is truly the viral load. That's how much virus is detectable in the blood at any given time. The higher that number is, the more copies of virus that are present, the more likely with any given exposure that there's going to be transmission of HIV. When we give patients treatment for their HIV or antiretroviral therapy, that brings that viral load down, and therefore it makes them much less infectious. So this is also from the CDC looking at transmission along different aspects of the HIV care continuum. So when you look at people who had HIV but didn't know it, or those who knew they had HIV but weren't in care, those who were in care but hadn't really gotten full viral suppression, compared to those who were taking HIV medication and fully virally suppressed. You can see right here, those who are on medication were essentially responsible for no individual transmissions of HIV. So this data really led the CDC to actually endorse this concept where people who take antiretroviral therapy daily as prescribed and are able to achieve and maintain an undetectable viral load have effectively no risk of sexually transmitting the virus to an HIV negative partner. So this has really been a huge change and really done a lot to help our patients kind of sort of free them up for being able to live more and more of a normal life. That doesn't necessarily mean zero risk. It is significantly decreased, and it really does require achieving and maintaining an undetectable viral load, and oftentimes requires our patients to take their medications as prescribed. So if they stop their medication for whatever reason, maybe they have side effects, maybe they have changes in their insurance coverage and they aren't able to get it, they do have increased risk of transmission. And so really our success for using this as a prevention method really relies on identifying all the individuals who are living with HIV and then establishing programs to help them get into care and continue to take their antiretroviral therapy. And as we'll talk a little bit about, we also have long-acting injectable medications that patients can use for their to treat their HIV, which can also help with adherence as well. So pre-exposure prophylaxis. So hopefully most people joining us today have at least heard of PrEP or pre-exposure prophylaxis. But the concept here is using HIV therapy or antiretroviral therapy for individuals who aren't currently infected with HIV in order to prevent their transmission. And it really can decrease the risk of getting HIV through sexual contact by 99%. And then estimates for injection drug use are by 74%. So it really is quite effective and can really help us slow the spread of the virus. There are currently 3 approved medications, 2 oral options, and a long-acting injectable option. The other thing, this does sort of hinge a little bit on patients actually taking their medication. So that's why a lot of people become more interested in the long-acting injectable as an option. So who might be candidates? So the CDC identifies lots of potential candidates. So some are what we consider serodiscordant couples, where you have an HIV uninfected sexual partner of somebody who's living with HIV. Individuals who engage in high-risk sexual behaviors, so frequent sexual encounters with infrequent condom use, sex with partners who are also at high risk for HIV infection or had a recent documented sexually transmitted infection. Individuals who have used post-exposure prophylaxis more than twice in the past year, and I'll talk about that briefly. Individuals who report injecting drug and sharing needles or other types of drug use equipment, or even very concerned patients who ask about it but may not want to disclose their specific risk factor should also be considered a candidate for PrEP. So in rural areas, we're not doing as well as they are nationwide. So since the FDA approval of PrEP, there has been an increase of its use in the number of providers who are comfortable prescribing it, but there's still areas in the US with limited access. A lot of different reasons for why we may have decreased availability in rural areas. So stigma is still a big one. Cost, provider availability, really just providers who are comfortable providing it and prescribing it. And then also potentially travel distances is frequently a barrier for some of our patients. So one of the things we're hoping to accomplish with this Project ECHO program is to hopefully increase the number of providers who are comfortable with and knowledgeable about PrEP and provide some real-time consultation for patients that you think might be good candidates. So some strategies to increase PrEP uptake. So integrating again with other services such as STI screening programs or harm reduction programs, frequent PrEP screening and offering. So really want to hope that people recognize that the indications for PrEP are dynamic. So somebody who might not be engaging in high-risk behavior at today's clinic visit, that might change in a couple of months. So need to screen and address it frequently. And many individuals are offered PrEP on more than one occasion before they actually initiate it. So it's continuing to have those ongoing conversations with patients. Streamlining clinic procedures. So initiate at the initial visits for individuals who don't have any obvious contraindication, and then using ancillary staff to provide education and adherence counseling so that the providers can see as many individuals as possible. And minimizing some of those in-person follow-up visits where possible so that patients don't have to take time out of their day to come into a clinic and maybe use some telemedicine services. And then a little bit on post-exposure prophylaxis. This doesn't get quite the headlines that PrEP does. But the concept here is using antiretroviral therapy after a single high-risk exposure to prevent HIV infection. So this would be somebody who had a single high-risk sexual encounter, maybe a condom broke, or maybe they had a single high-risk injection exposure. The big thing here is the timing. So it really has to be initiated within 72 hours. The sooner the better, but definitely within that 72-hour window for it to be effective. And the CDC does provide guidance for both occupational exposures, so healthcare workers who might sustain a needle stick injury, for example, and then also those non-occupational exposures, such as the high-risk sexual encounter or injection drug use exposure. Non-occupational exposures. So it's recommended following non-occupational high-risk exposures, including sexual exposures such as a sexual assault, sharing of injection drug use equipment. It really shouldn't be thought of as a substitute for other HIV prevention methods and not recommended for individuals who are exposed to HIV frequently. That's really somebody you want to think about PrEP for. But if there's a single high-risk exposure, it should definitely be considered. Again, it needs to be started within 72 hours of the exposure, the sooner the better. And then it's continued for 28 days with frequent follow-up testing. So here's a flow chart from the CDC. So again, if they have a single exposure with a substantial risk for HIV infection, then and it's been less than 72 hours, if the individual is known, the source person was known to have HIV, it is recommended to do non-exposure PEP. If this HIV status was unknown, they recommend a case-by-case determination, though most providers probably would offer it in that situation as well. So just a summary, so there's multiple strategies now. That was just a quick overview of ways to prevent transmission of HIV. So treatment is prevention, so identifying all those individuals who are living with HIV and getting them in treatment and care and getting them virologically suppressed. Pre-exposure prophylaxis, and then post-exposure prophylaxis, both occupational and non-occupational. Recognizing that we do still have some ongoing disparities in our rural communities for accessing appropriate HIV testing, treatment, and prevention services, and starting to use some of these strategies to improve access to appropriate HIV treatment and prevention services. That's just our contact information for our group here at the Mid-Atlantic AIDS Education and Training Center. So as I think Alyssa's on the call, she's our interim regional coordinator. And I might have forgotten to tell you this, I'm the regional director starting this year as of our Mid-Atlantic AIDS Education Training Center. And that's what I have. So I'm happy to have, if there's any questions or comments, or Kaylee has some, also has some case examples to take us through as well.
Thank you so much, Dr. Bryan. That was very informational and helpful. There was a question that Kaylee had answered, but in case anybody didn't see it, Sarah had asked if there was a way for patients to check their viral load whenever they were at home. And Kaylee had said that the answer for that was unfortunately no.
Yeah, the actual viral load, that's a PCR test. So that's really something that's run by us in the clinic and is done by a specialty lab. So currently not. They can do home HIV screening tests, which look for the antigen and antibody, but that actual PCR test that gives the quantitative viral load, that's something that's done by us in our clinic and by a healthcare provider. That's a great question. We do, and I'm sure most places do, with the use of electronic medical records now, a lot of times patients can view their results. And so a lot of patients like to see that undetectable number and have access to it. But that is something they have to be in care usually to actually get that number. That was a great question.
Thank you. Sorry, I just want to make sure everyone was able to see that. Kaylee, if you are ready, we will go ahead and start. I will share my screen with you.
Thanks, Kelly. Thanks, Dr. Bryan. That was such a good overview. Very descriptive. So I think that I want to start, this is our very first session. And I want just everyone that's on the call, or if you plan to join the calls in the future or have people that do, we try to be approachable and informal. So all questions, we definitely want people to ask questions. We want to do our best to explain. Certainly if we don't know the answer, we'll find it for you. But I'm kind of interested to know, I know there's some providers that are logged on. I know there's some individuals on that aren't providers. I know we have some people from out of state and out of the country. And so I just kind of wanted to see, and you can either respond through audio or type it in the chat, but just what you all are hoping to gather from these sessions. Anybody's welcome to talk.
I'll volunteer as tribute. I just like to stay current on all the updates, and so that's my motivation for calling in.
Awesome. Okay, thanks, Angie. Yeah, I think good real life case studies and more information to be able to educate. Awesome. And so, I mean, we have a whole series of didactics that we'll focus on for each session, but I also encourage you all to also present cases. So if you have any patients that are at risk for HIV, particularly if there's patients that you're wanting to start on PrEP, if you don't feel quite comfortable prescribing PrEP yet, or even just want to run a case by us, we certainly encourage that. We can review them together at one of the sessions. You can always reach out to us in between the sessions and we can offer recommendations too. But this is our HIV case form. Kelly, do I have are you able to share the screen? Or is there a way that you can actually just pull up, not my case that I submitted, but actually the form as if we were going to submit one together? Because I want to see, I just kind of want to go through the case form. Yeah, like that. Yep, perfect. So I was going to present an HIV case or PrEP case today, but I think since it's the first session, it might be useful just to go through the form together, and then I can just kind of go through as if I'm submitting a case. Somebody else said, has my chart been updated to reflect information that viral loads below 200 copies are considered suppressed versus fewer than 50 copies? As a patient, results of the new higher sensitivity test show that any viral load over 20 is being high, which can be disconcerting. Yeah, Marcus, that's a really good question. So it depends on the lab. I know here at Ruby, our testing can detect as low as 20 copies. And so our test would still say undetectable if it's less than 20 copies. it might even be less than 10 copies, Dr. Bryan, if you wanted to correct me on that. But it just really depends with the lab as to how sensitive the actual viral load test is. So yes, it's still going to reflect that less than 200 is virally suppressed. That's per CDC guidance, but at our with our lab specifically, we just have a lower sensitivity test, so that's why it reports that way.
Yeah, and we have recently, Kaylee, here at WVU, so the lab has certain reporting requirements, so they have to flag it. So anytime it's detected, it will get like a little like red exclamation point or whatever. So it'll get an abnormal flag, and that has to be done. But we have recently, in the past couple of months, there's actually a statement where we put the CDC statement with the lab that accompanies the lab result, where we say that the CDC does consider less than 200 copies per ml to be virologically suppressed or undetectable for their purposes. So we've added a statement here to ours, but you still get that little red exclamation point.
Sure. Okay. Awesome. Thanks. And then someone else put a comment in that they're hoping to learn to stay connected with best practices and learn from different areas surrounding Maryland. Due to funding contractions, prep programs may change in the current fiscal year. That's something we unfortunately see a little too often. Other people writing, they just want to stay updated and able to update their providers. Awesome. Okay. Yeah, so that's helpful. So the prep form, I'm just going to go through our case form. When you first log into REDCap, and Kelly sends out with the reminders a link to this case form. So if you have somebody that you want to present, then you can just click on the link and it'll just take you through. But we want to know, your name and title, so we know where you're coming from, certainly email address, so we can follow up with any recommendations, and then your organization. County is also helpful. It just helps us to be able to have that reported, so we kind of know what providers are following in what areas. And then case presentation date, if you click on that drop down box, you can actually select. So we can select for me today, but if you're not able to present a case until one of the future sessions, you can also mark that as well. And then we'll plan to have your case presented at that session. So with my patient that will present today, I'm going to say this is a new consultation. So if you have somebody that's already on prep, you could select follow-up, but with this one, this is going to be a new patient. The patient I'll present, it's a 22-year-old cis male. So they are presenting for just routine STI testing to a primary care clinic. So this patient's not currently on prep. I would select no. We'll just say the visit date is today, 22-year-old. And then we may have to fix that instead of cis male and female. It's a little typo there, so we can edit that form. Go ahead and scroll down, Kelly, if you don't mind. This is a white cis male. Insurance is WV Medicaid. And if you have Ohio Medicaid or Maryland Medicaid or anything out of state, you can also type that under other. So that way we know, because sometimes the preferred regimens are a little bit different, varying between insurance. So like I said, 22-year-old male that's presenting for STI testing. We'll just say that this patient really has no significant medical history. We'll say he's not on any current medications, no drug allergies, reports 6 male partners in the last 6 months. So in terms of risk factors, we can say high risk sexual behavior. And if you are going through this form and you leave something blank, we may ask, you don't have to necessarily fill out this form completely, but it is helpful for us so we can direct our recommendations. So he does not know of any partners that have HIV, but a lot of his sexual behavior or sexual practices are they're anonymous encounters, so he doesn't necessarily know, but not to his knowledge does he have any partners with HIV infection. We also like to specify which type of intercourse they partake in. This is helpful for us to know, so that way we can counsel appropriately. So this patient engages in receptive anal intercourse, or he bottoms. He also engages in oral intercourse, and he both receives and gives oral. So that's helpful for us. Receptive anal intercourse in terms of sexual transmission risk is highest for HIV transmission. So we'd want to make sure to counsel on that. He does not use condoms consistently. Some patients use condoms consistently with certain types of intercourse, but they don't with others. So as specific as you feel comfortable with, the more information, the better. Also, not just for us, but to ask your patients. This also helps us with STI testing. So if you're only asking, are you sexually active? You may just be doing HIV testing, syphilis, urine gonorrhea, chlamydia, hepatitis C, should be doing Hep B testing as well, for those that are applicable. But we also recommend 3-site testing, so oropharyngeal and then rectal gonorrhea and chlamydia testing, which are swabs that tend to be collected in the clinic. And so if you're not asking which sites are being utilized with sexual intercourse, then you may be missing those testing, and you might miss infections. So that's why it's important for us to be specific. I'll have a didactic, I think, in a few months about how to take a sexual history, so we can get a little bit more comfortable with that. Because I know if you're not used to it, it can sometimes be a little bit uncomfortable even for providers. This patient says he's never been on PrEP before. Doesn't really know much about PrEP. And then past medical history, like I said, no significant past medical history, no history. Specifically, we're looking at kidney disease, bone disease, history of cardiac disease, anything that would involve potential steroid use, because those conditions can really impact which treatment selection we choose for PrEP. And then, kidney disease, liver disease, those types of things. So this patient has done a home test in the last month. We do not have any HIV testing on file. So if you're writing this, you can do, we don't have a space for home test, but you can type that in the comments box. And he reports a home test in the last month that was negative. All right. And then it's also important for us to know hepatitis B status. So if he's not been tested for hepatitis B, you want to do full serology. So hepatitis B surface antigen, surface antibody, and then core antibody. All of these were negative. And so he does not have a history of hepatitis B, does not have active hepatitis B, but we should be offering vaccination. Some of the PrEP medications, particularly both oral regimens that we have available, they also treat hepatitis B. So it's important for us to know Hep B status so that we're not inadvertently treating someone's Hep B, then they decide that, hey, I don't want to be on PrEP anymore, and then we're inadvertently inducing a flare. Hepatitis C is also important. We should be doing that for all of our patients that have never had a screen before. If patient's risk factor for HIV acquisition would be injection drug use or high-risk sexual behavior, we'd also want to do Hep C antibody screening. He had this, we did this when he presented for STI testing, and it was negative. Hepatitis A, total antibody just tells us if they have been exposed or vaccinated. That was positive, meaning he's already been vaccinated. And then syphilis, we also went ahead and did oral, rectal, and urine gonorrhea and chlamydia. Those tests were all negative. And then
Should I be checking those as negative?
yeah, you can do negative.
Okay.
And then we did not check his CBC. So we don't enter that. And then renal function, we also did not check that. So we'll leave that blank. Same with the hepatic panel. We did not check that. So we'll leave that blank. Since he's just presenting for STI testing, we didn't check the lipid panel, so we can leave that blank as well. And then medications, none. So we already have this patient that's tested negative for HIV via home test, tested negative for STIs when he presented. He's had multiple partners in the last 6 months with both oral and anal intercourse with inconsistent condom use. And so we've discussed PrEP with him and he's interested in starting. Things that we want to check before we start him on PrEP. So one of the things is making sure that doesn't have any signs or symptoms of HIV, acute HIV infection, which he does not. It reports to be in his usual state of health. It's important for me to know when he last had unprotected intercourse. If he had unprotected intercourse 2 days ago, then, certainly his home test is not going to be sufficient, but we also want to make sure that if we're starting him on PrEP, we know when that last unprotected case was, in case he does develop HIV, then we can narrow that down. We did check in. We will go ahead and check an HIV antigen antibody test in clinic. That's going to be a lot more specific than a home test. And so we did that. That was negative today. We should not be starting PrEP unless we've checked baseline renal function. So we'll have to make sure to go back and do that. Let's say we did that and his renal function's normal. So we really have all options in terms of our PrEP. There's 3 medications that we can use, 2 oral regimens, and then 1 injectable option 2 currently. Let's say this patient had a partner that does have a history of HIV. So let's say that he has a partner that he was with 3 months ago that doesn't have HIV. Questions that we would want to ask is most importantly, do they know about that partner status? Is that partner on treatment? Are they undetectable? They may say they don't know. So, but that's something that we should be counseling patients as well, is that if you do have a partner that's HIV positive, are they on treatment? Are they undetectable? How long have they been undetectable? If their partner's undetectable on treatment for the last 6 months, as Dr. Bryan had stated in her talk, there's virtually no risk. So it's negligible risk of HIV transmission sexually. So I don't worry about those partners. I worry about partners that aren't getting tested for HIV, or aren't disclosing their status, or aren't or are HIV positive and not on treatment. So we want to make sure that we know that too and counsel our patients. Let's say that the patient presented to your clinic for follow-up because he was recently in the emergency room and was prescribed NPEP. So NPEP, as Dr. Bryan had said, is if a patient was started on non-occupational post-exposure prophylaxis after an HIV exposure. And so if a patient is already on NPEP, it's a 28-day course of antiretrovirals. You can immediately transition them, if appropriate, to PrEP. So there's not a waiting period to start someone on PrEP if it is something that would be appropriate for them. So basically that's kind of the case form and how it works. We don't expect you to already have everything filled out and already know what regimen that you're going to have the patient on for PrEP. I just really wanted to kind of go through the form just to show you what we tend to look for. If you don't have that data available, it's fine. We can always just recommend it. But those are the specific things that we look for when we're going through the form. So with this patient in particular, we've determined he's HIV negative. He doesn't have any signs or symptoms of acute HIV infection in the last 4 weeks. So I feel comfortable starting him on PrEP. At this time, if he does develop any symptoms of HIV infection after starting PrEP, that I want to make sure that we do follow-up HIV testing, because we may be missing that window period of acute HIV and have him on like a partial antiretroviral regimen. That's not super common, but we still want to be aware of that. So 3 options. We've decided to start him on oral PrEP. with Descovy. It's a 1 tablet you take once a day. With him, he doesn't have any real past medical history. Kidney function is fine, so we can go ahead and start him on that. With oral prep, you usually can just prescribe it the same day. I tell patients that they can go ahead and pick it up from their pharmacy if they'd like, or at least check to see if they have any copay. But I tell them not to start it until we've confirmed that they have an HIV negative test. So we've started on that, and then I tend to follow up in a month and just see how they're doing. So I know that was a lot, but I kind of I just wanted to go through everything of our form. Do you guys have any questions for the form itself? Anybody have any cases that they have started somebody on PrEP recently or are not sure which regimen that they want to start with PrEP? We have about 5 minutes, so can you speak to the Descovy black box warning? Awesome, Marcus, you rock. Yes, so the black box warning for Descovy is in relation to hepatitis B, and that is with hepatitis B that is active. So saying that what I mentioned, that you want to know their hepatitis B status. If a patient has active hepatitis B, so hep B surface antigen is positive, then it's not that you can't start Descovy, but since it has tenofovir in that antiretroviral regimen, then the danger is if they stop, it can induce a flare. And so that's the black box warning. We want to make sure we know their hep B status. And then, like I said, go ahead and start the vaccine series if they're not already immune or if they don't recall being vaccinated against hep B. And then also prescribing Descovy for patients with a receptive vaginal sex as the risk factor. You are awesome with the questions. I'm not going to have anything to talk about next time. No, these will be things that I go over next session as well, because we'll go through all the PrEP medications specifically. But in terms of prescribing Descovy for patients that have receptive vaginal risk factor, Descovy is probably fine to use, but it has not been FDA approved. And so there is a study that's ongoing currently for Descovy for receptive vaginal sex, but right now it is not a medication that we recommend for receptive vaginal sex. So options would be Truvada or cabotegravir.
Thanks. One other comment I just wanted to make, just to make sure everybody is on the same page. So the big difference and why we focus so much on HIV testing before starting PrEP is PrEP medications, yes, they are antiretroviral therapy and they target the virus, but it's not a fully active treatment regimen. So if you have somebody, so the concern, if you have somebody on PrEP and they acquire HIV or they have early HIV and we're not detecting it, they can develop resistance to those particular medications. So that's why HIV testing, and we're going to have a whole session devoted to all the different types of HIV tests out there and how to interpret them. But that's why Kaylee says, yeah, I'll give them the prescription, but we need to make sure that that test is negative before you start taking it, so they don't develop resistance to that medication. That's a little bit different from post-exposure prophylaxis, which is a fully active regimen. And so when she talks about transitioning from post-exposure prophylaxis to pre-exposure prophylaxis, basically you're kind of taking away a medication there. And so that's just kind of a clarification. That's why those two things are a little bit different. And so why we're going to focus a lot on testing and interpretation of testing when we start PrEP.
Thanks, Dr. Bryan. Any
All
other
right, does
questions?
anyone else? Go ahead.
No, I was just gonna say, any other questions?
All right, well, for the good of the order, I want to thank you, Dr. Bryan and Kaylee, for both presenting great material to everyone today. And thank you for taking the time. So our next session is going to be September 5th with you, Kaylee Berner, presenting the topic of pre-exposure prophylaxis or PrEP medications to the group. And remember, guys, if you have a case that you would like to present, you can send those in. And if you have any questions, feel free to reach out. Other than that, thank everyone for their time and see you next time.